Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos if you are visiting for the first time. Okay, so in this video, we will discuss a new topic related to the hematology, that is microcytic hypochromic anemia. As all of you know, hemoglobin, if it is less than 10 gram per deciliter, according to World Health Organization, is called as anemia. But that anemia can be depends upon the hemoglobin according to the age and sex. In males, if it is less than 13, and if it is in females, it is less than 12, and in children, if it is less than 11 gram per deciliters hemoglobin, then it is called as anemia. Morphological classification of anemia includes normocytic normochromic anemias, microcytic hypochromic anemias, and macrocytic anemias. The normal size of RBC will be 7.2 microns, which is equal to the approximately equal to the nucleus of a small lymphocyte. So if it is less than the size of a small lymphocyte, then it is called as microcyte, and if it is more than the size of a small lymphocyte, more than 8 microns, then it is macrocyte. And if it is more than 10 microns or 12 microns, then it is most of the times it is called as megaloblast. Now, the microcytic hypochromic anemias. Microcytic hypochromic anemias can be seen in iron deficiency anemias, anemia of chronic disease, sideroblastic anemias, and thalassemias. Rarely, lead poisoning will come on under microcytic hypochromic anemias. So, iron is observed in duodenum. Iron deficiency anemia, anemia of chronic disease, and sideroblastic anemia and thalassemia can be differentiated basically on the mainly first it is the parameter we use is RDW, red cell distribution width. Red cell distribution width is high in iron deficiency anemia and normal in thalassemia. Menger index is M by R, that is MCV by RTW. It is approximately around 13. If the Menger index is more than 13, it is iron deficiency anemia, and if it is less than 13, it is thalassemia. Now coming to iron profile. In the iron profile, we will check for serum iron, transferrin saturation, ferritin, and total iron binding capacity. The serum ferritin or ferritin is the storage form of iron. Iron is also stored in the form of hemosiderin. Serum iron and transferrin saturation are directly proportional. Transferrin has capacity to carry 6 iron molecules. Minimum 2 molecules are being carried. So 2 by 6 is 1/3, that is 33% transferrin saturation is normal. So the serum iron, if it is less, the transferrin saturation will be less, and if the serum iron is more, the transferrin saturation will be more. And the storage form ferritin is indirectly proportional to the total iron binding capacity. That means if the storage levels of iron, that is ferritin, is decreased, then the total iron binding capacity will increase. And if ferritin levels are increased, then the total iron binding capacity will decrease. So with this basic knowledge, if we check in iron deficiency anemia, the serum iron, transferrin saturation, ferritin will decrease and total iron binding capacity will increase. Opposite to the iron deficiency anemia, that is sideroblastic anemia. So here more and more iron is present. So serum iron, transferrin saturation, and ferritin levels will be increased, whereas the total iron binding capacity will be decreased. Coming to the anemia of chronic disease, the serum iron levels and transferrin saturation levels are decreased. As the ferritin levels are being increased, the total iron binding capacity will be decreased in anemia of chronic disease. So the stain that is useful to identify the iron stores in a bone marrow will be Pell stain or Pell's Prussian blue stain. Thank you for your patient listening. Please like, share and subscribe Dr. Ravichandra Official for more interesting videos on pathology.